He'll get in now.
Just request him to turn on his video so that we can find him when he gets in.
Yeah.
Johnny, please admit everybody. I'm doing the YouTube
meeting password.
I'm doing the YouTube link
now.
Okay.
Who's that? Is that you?
Request him to turn on his video so that we can find him when he gets in.
Yeah.
Johnny, please admit everybody.
Sorry. Okay.
I'm doing the YouTube link
now.
Okay.
Who's that? Is that you?
Request him to turn on his video so that we can find him when he gets in.
Yeah. Zulfi.
Johnny, please admit everybody.
Hello, Curio.
Is that you?
ഇല്ലില്ല, then you got the പഴയതായിരിക്കും, പുതിയ ഇന്നത്തെ ആയിരിക്കില്ല. അല്ല, ഇത് അയച്ചിട്ടുണ്ടല്ലോ. അയ്യോ, അല്ലല്ല, ഞാൻ ഏതിലാ ഇത് ജിമെയിലാണോ വേണ്ടത്? ഇതില് it is sent to you. He hasn't got the ഇപ്പോഴത്തെ password.
I'm sending it again to him.
96 in the password ആണ് പുള്ളിയുടെ കയ്യിലുള്ളത്.
I sent it.
Acha.
I just sent I sent him that PDF that you sent in the WhatsApp group, so he can click on that. That's how I got in. I sent it via WhatsApp again. I think he will get in. Somebody can call him and guide him while we start the program.
I think so. ഇപ്പൊ കിട്ടിയോ പുതിയത്? അത് വാട്സാപ്പില് അല്ല, കൃഷ്ണമാർ അയച്ചെന്ന്. Okay, shall we start then? Keep if it comes to 90, then just stop, Johnny, so that once we get him in only, then you 100 across the Amadi. Okay, shall we start?
Okay.
Okay.
Good evening, everybody.
Good evening.
A warm welcome to everybody. This is the fourth in the series of the Pediatric Potpurri, conducted by IAP Cochin branch in association with the Kerala State branch. We have a galaxy of speakers today to talk about one specific problem in cardiology. And to conduct the proceedings, I request Dr. Jason Uni, Chair, to carry on. Thank you.
Thank you, Dr. Pramod. So today is another feast of academic activities where we're going to dissect tachyarrhythmias in children. And we have a galaxy of speakers, as Dr. Pramod has said. We're going to discuss a few cases, and we're going to talk about how we'll approach this problem and simplify it. It's quite a difficult issue, a difficult part of pediatrics for general pediatricians. So we would like all the cardiologists who are involved today, Dr. Edwin, Dr. Krishna Kumar, Dr. Zulfikar, and Dr. Ajit, to demystify this, to make it simpler so that people can understand how to approach tachyarrhythmia in children. And we'll start the proceedings with, I'm just sharing my slide. This is the Dr. Krishna Kumar, who will oversee the whole proceedings. He is going to give the initial intro into the subject. He'll do the summing up, and he's doing a quiz. So Dr. Krishkumar, I mean, he's known not only in India, but all over the world. And he is the clinical professor and head of Department of Pediatric Cardiology at the Institute of Medical Sciences and Research Center in Kochi. He's got a DM from All India Institute, New Delhi, and fellowship in pediatric cardiology from Children's Hospitals, Boston. He's established a premier pediatric heart program at the Institute of Medical Sciences. And the program has been awarded DMJ Award for Quality Improvement in 2014. Establishment of great large community-based studies on rheumatic heart disease, something that is close to his heart, and in South India. And he's got a fellowship training program in pediatric cardiology under the National Board of Examinations, and the first DM course in pediatric cardiology. So he's the immediate past president of the Pediatric Cardiac Society. I present to you Dr. Krishkumar.
Thank you, Dr. Unni, for this very kind introduction. I think you put it across very nicely. The whole issue of arrhythmia is terrifying to the average pediatrician, especially the students at the first encounter. And as you said appropriately, the idea is to demystify it. Now, I think the one thing that we as cardiologists and specialists, when we talk to a more general audience, is to avoid jargon. And what mystifies our whole specialty is when we keep coming up with big jargons one after the other, then it tends to get very difficult for the audience to follow. So I think we have to keep it incredibly simple. But the truth is, arrhythmias, when it comes to the level of initial emergency care in the casualty at the first encounter, is actually pretty straightforward. It isn't something that should cause undue amount of panic. So what I would just emphasize, I'm sure Edwin would talk about it, is there are 3 or 4 rules. As a first encounter, you have a unique opportunity to capture the arrhythmia and document it, and document the effect of giving treatment such as adenosine. Yeah. This will be a service for a lifetime for the child, because once the child has a documented arrhythmia with a documented response, you have paved the way for a very precise diagnosis for the child, and you've done the child a lifetime's favor. It's actually not so important to terminate the arrhythmia and send the child home. It is far more important to document the arrhythmia and give the child a clear view for the diagnosis in future. If the events occur, then everybody knows exactly what's going on. And electrophysiologists, for instance, can plan their therapy, drugs can be tailored, etc., etc. So it's very, very important to document. The second real key issue is really not to panic. The problem that really happens is a child comes to the emergency room, is hooked onto a monitor, parents are super anxious, everybody is panicking, the pressure is intense on the pediatrician to try and solve the problem and get rid of the arrhythmia and produce a sinus rhythm. That pressure is there, no doubt, but the urgency should be only dictated by the patient's condition. If the patient is falling apart, is hemodynamically unstable, then you need to cardiovert. Otherwise, you have time. You have time to document, at the very least, 3 or 6 lead ECG, if not a 12 lead ECG. Even if you don't have any ECG facilities, at least document and show the rhythm on the monitor and capture that event as you give the treatment. So it's very important to do that, not to panic, because 99% of pediatric arrhythmias, 95 to 99% are stable. Particularly if there's no heart disease, then 99% are relatively stable. You have the time. So today's talks will be delivered by Edwin, who will talk about the approach. Dr. Zulfikar will talk about drug therapy, and Dr. Thachil will talk about how to manage this when drug therapy fails and you have to do something in the cath lab to permanently take care of the arrhythmia circuit. And then, of course, we have the quiz, which I'm sure you'll be able to answer substantially once you're through with this session. Thank you, and over to Edwin.
Thank you, Dr. Krishnakumar. And now we'll go on to
I'm on mute.
Dr. Edwin. Please
Yes.
share your slides.
Yeah, sure. Am I sharing my slides?
Dr. Edwin is the head of Department of
Yes.
Pediatric Cardiology at Lisi Hospital, and he's going to talk about approach to tachyarrhythmias in children. He's
Am I?
Yeah, it's
this is
fine.
visible.
Yeah,
Yes,
put the next
yes.
slide. Next slide. Yeah. So he's the one in the blue shirt. He hasn't got his photograph on this by status
Oh,
size.
sorry, yeah.
He's one in the blue shirt who is the young pediatric cardiologist at Lisi Hospital. He did his DNB and MD pediatrics and fellowship in pediatric cardiology, DM and DNB in cardiology. He was in Amrita Hospital earlier and now is the chief of pediatric cardiology at Lisi Hospital. His special interest is advanced structural and congenital interventions. Got 30 or more publications in international and Indian journals. The gold medalist in final MBBS. This is the best paper award, the Asia Pacific meeting.
It's
in-
fine.
So he's been to many lectures, and so we're going to hear a lot more about him in the near future. He's going to talk to us about approach to tachyarrhythmias. Over to him, Doctor.
Thank you, Dr. Jason. As Dr. KK has already clearly mentioned in the beginning, it's basically the two basic things, like not to panic and come to a diagnosis. I think many of the slides was probably they all been shared when I was in Amrita also, so it will be all the same theme when I talk about it. To start off, like arrhythmias as infants, has been again said, it is a difficult thing for the parents or the patient. Obviously, the infants, predominantly the infants present. So the parents present with non-specific symptoms because either a fast breathing, lethargy, a poor feeding, or just many a time they just say the baby is not just doing well because it may not be picked up by the parents. While for a pediatrician, it might be quite easy, like just you need to see the heart rate alone. But then even having said that, many times we do see that in a hurry or probably in an emergency, maybe you may not look at the heart rate exactly clearly because a small infant crying, you think the heart rate is around 160, 170, but then
Correct.
yeah. So it may be still missed by a pediatrician, but then I don't think in Kerala this story is different. So I don't think hardly any SVTs are missed here. So that's a way they present mostly. And then even though they are mostly present as a non-specific symptom, few may come to the emergency with palpitations, pre-syncope or syncope. It's usually an older child. And many times it may be non-specific, but few, if you don't check the heart rate or ECG, you may miss a SVT. So what is the immediate management? The first thing when you identified a SVT or a VT, whatever, a tachyarrhythmia, the question is, you see the hemodynamics, the BP, blood pressure, and the perfusion. If it is not stable, like if pulses are not felt, the pulses are weak, then you don't have time to think. You have to quickly act then. A ventricular tach, most likely it could be a ventricular tachycardia or SVT in trouble. Then you have to immediately desivert and start resuscitating. While when the pulses are felt, which as Dr. KK said clearly, 95% of the time, it will be a more stable patient with stable hemodynamics. We need to diagnose, and then we're discussing this part of the patients. 5% you may have to go immediately, but 95% you need not panic and then try to diagnose before you go in. There are a few essential steps in the management of a patient's arrhythmia. As I said, don't need to panic. You need to monitor BP, pulse, and the breathing pattern. But you may, anytime during the SVT or VT patient may collapse, so you need to be careful. But same time, you need to be under situational control. As I said, there's no need to rush to treat. You need to identify the tachycardia before you go in. And an ECG on the monitor can be misleading. So almost always try to get at least a 6-lead ECG or a 12-lead if possible. The many places you may not have that 12-lead, but at least take a separate, at least a limb leads be recorded before going ahead with treating the patient. Just for an example, is a 14-day-old newborn came with history of bit of lethargy and with tachypnea and lethargy. And then heart rate is noticed to be 280 and was referred as a tachycardia from the peripheral hospital. His peripheral pulses are a bit weak, and then severe short cardiomegaly. But there is no murmurs. So this is the ECG taken. This is a full 12 lead ECG here. The question is like, what do you do next? Like, well, it's a better, like as a pediatrician, initially trained as a pediatrician, we are always in the pediatrics, you're a bit poor in the ECG reading. But then now I think things are different because around nearly 20 years before after I finished my MD. So now PGs are quite good in interpreting an ECG, but I initially started my fellowship program. I was like, I didn't know much about interpreting an ECG. But here, if you get a 12 lead ECG here, the first thing you look at is, what are you looking at? First thing you'd like to know is the heart rate, the very basic thing. Then whether it is a narrow or a broad QRS complex tachycardia. If it is a broad QRS, you know you're probably dealing with a probably dangerous form. You need to think and act faster. But it's a narrow QRS. Most of the time, you have enough time to think and identify the diagnosis. And thirdly, probably it's a regular or irregular. The very basic things you should look at when you find a patient with SVT or VT. The first step is to identify the heart rate. I think this is very basic, but majority of you know about it. Basic rule is 1500 divided by number of small squares. You may identify the small squares and divide it by 1500, or it's much more easy to have a large square, 300 divided by number of large squares. The more even a simpler rule is, this is the graph here. That's one large square, it is 300. Two large squares is 150 is the heart rate, 300, 475, and 560. So once you identify here, that's just beyond one large square, maybe nearly six and a half small squares. Heart rate will be around 270, 280. So next is whether it's a narrow QRS or a broad QRS. The narrow QRS tachycardias are, majority of the SVTs are, majority of 98 or 99% of SVTs are narrow QRS. And then predominantly because it originates above the His bundle and traverses through the regular conduction pathway. So the excitation of the ventricles are normal. While in a VT, ventricular tachycardia, the majority of the ventricular tachycardias originate from the ventricle itself, not to the vesicle, so except that probably a few of them. Majority of them, for practical purposes, all of the ventricular tachycardias tend to be a broad QRS. Again, what exactly is a broad and a narrow QRS? The one ECG I showed is obviously it's quite narrow, but it comes to a few scenarios. In an older child, it might be a bit difficult, but in majority of the cases, less than 100 milliseconds of QRS duration can be taken as a narrow QRS. While in adult, definition-wise, it is more than 120 millisecond QRS duration. So in this, again, back to the ECG, it is a heart rate is around 280. You have a narrow QRS tachycardia. The next thing you may need to look into is probably the mechanism of tachycardia. If possible, if an idea about it, whether that's a re-entry, the major mechanisms are re-entry and automaticity and very rarely triggered activity. What are the features of an irregular tachycardia? Because next thing we need to know is what is regular, what is irregular. What are the common types of irregular tachycardia? An atrial fibrillation is one of the commonest irregular tachycardias, but not in the pediatric age group and almost rare in infants. A flutter is more common. A flutter with variable conduction to the ventricle results in variable heart rate and irregular tachycardia. And EAT, again, it's a bit common in pediatric age group. Except for a few of these, majority of the tachycardias are regular. And even in the atrial flutter and ectopic tachycardia, few may be regular and few may not be regular. So coming back to the same ECG again, here you have a relatively stable infant with a heart rate of around 280 per minute and with a regular narrow QRS tachycardia. Next thing you look at is whether you can identify the P waves or not, whether there is an AV conduction is seen or VA conduction is seen, is the P waves as equal to the ventricular QRS complexes. So we need to differentiate if the tachycardia is, whether it is a mechanism due to whether it's re-entry or automaticity. So a re-entry tachycardia, the commonest tachycardia in the pediatric age group is the AVRT, in which there is an excessive pathway, which the normal conduction happens through the AV node and the retrograde conduction happens through the accessory pathway, the slow pathway, and then this forms a circuit which results in persistent excitation of the ventricles, resulting in a AV reentrant pathway in tachycardia. So these are the classical examples, as I said. So when you go to it, these are the features of a tachycardia. But while in the case of reentrant, you have a sudden onset and termination because of the reentrant circuit coming in. You have a fixed heart rate, the tachycardia goes on, and usually cardioversion is effective in these reentrant tachycardias. While in an automatic tachycardia, it's more rarer, usually have a warm-up and a cool-down phenomenon. The heart rate tends to vary, and cardioversion is usually ineffective, and you need to give drugs which need to suppress automaticity. Probably will be discussed later in detail. Again, as I discussed earlier, the majority of the tachycardias are mostly reentrant in the pediatric age group, and they are regular. So if you look at it, 90-95% of the tachycardias will be regular and reentrant type. So treatment becomes as very easy as initially described. Coming back to this again, so you have a regular narrow QRS tachycardia with a fixed heart rate. So what are you going to do next? I think everybody, most of the pages know that you need to know whether it's to give an adenosine administration. What does adenosine do? Adenosine causes an AV block, AVD. So then you can make out what's happening. If there is an AV nodal dependent tachycardia, like an AV nodal reentrant tachycardia or AV reentrant, atrioventricular reentrant tachycardia, it tends to get immediately abolished with a blockage of the AV node. So as you all know, the rest you can give undiluted adenosine is around 0.1 to 0.3 mg per kg. Preferably try to get a good IV line, probably the anterior cubital. If you have a single line, nothing like that, and then immediately flush with a three-way here so that it immediately reaches the heart. Try to sedate the baby before giving the adenosine, so the sympathetic stimulation is lesser and adenosine is more effective. Rather than a crying baby, you're giving an adenosine. So what is the action of adenosine here? As we already described on the mechanism, in the reentrant circuit involving the AV node, you have the sudden AV block happening and resulting in sudden termination. That is what usually happens in a AV nodal tachycardia or an accessory pathway mediated tachycardia like an AVRT, which is the most common SVT in the pediatric age group. While in the other cases, like other SVTs, atrial tachycardia, it tend to unmask it because atrial tachycardia, like an atrial flutter, it keeps going on while the ventricular conduction through the AV node is blocked by the adenosine. So the flutter waves become more prominent, more evident in atrial flutter or ectopic atrial tachycardia, but the tachycardia continues. While in another set of SVTs or tachycardias, it has no effect. Probably a ventricular tachycardia or a sinus tachycardia or a junctional ectopic tachycardia, it is unaffected. Probably in adults, there may be some slowing because of the effect on the sinus. So this is an old ECG which shows the classical conversion from the SVT with adenosine. It immediately breaks into a regular sinus rhythm. So the arrhythmia is terminated because of the loop is blocked by the AV node. So what next? Once you have done an ECG, this reverted, you need to get a 12-lead ECG again to identify these waves. I think most of you can identify that there is a short PR interval and there is a pre-excited delta waves seen in the QRS, which indicates there is an evident conduction during the sinus rhythm through the pathway, accessory pathway. Summarize, here is a regular Narrow Qrs tachycardia, which is the reentrant mechanisms, constant heart rate, termination with adenosine, delta waves, and the complete diagnosis AVRT with a WPW syndrome. Just one slide here, or few more slides. There is one word on pre-excitation. Normally, in the left side of the diagram, you see impulse coming from the SA node, going through the AV node, and forms a QRS. The PR interval consists of from the SA node into the completion up to the AV node, up to the His bundle. While if you have the accessory pathway, which not always need not conduct antigrade, it might cause a retrograde conduction and cause an SVT, but it may have a normal ECG. But in few percentages, 10-15% of cases, you may have this accessory pathway conducting antigrade also. So there is a pre-excitation of the ventricles, resulting in a shorter PR interval and slurring of the upstroke of the QRS. This is called the delta waves. We come to the next is a type of tachycardia. Here's an example here. I think it's quite evident. It's an old ECG here. You can see the classical sword wave tooth pattern. So how do you go about it? You can identify the pattern, well and good. If not, you look at it, it's a narrow QRS tachycardia with a heart rate of is around 7-8 squares, around 240, 250, and is a narrow complex with a regular tachycardia. So it's a regular narrow QRS tachycardia. You can probably see the pattern very well. You can identify it immediately. If not, you give an adenosine and see the effect. The first one we said is sudden termination. The second one we spoke about is the slow unmasking, unmasking of the tachycardia in a flutter or ectopic tachycardia. You can see on adenosine, you can see the flutter waves quite remarkable clearly. So the treatment involved is, as the DC version, 0.5 joules or 0.5 to 1 joules per kg is good enough. Majority of the time, 0.5 is enough. It will immediately get reverted most of the time. But a diagnostic approach, the traditional classification is narrow QRS, stable hemodynamic supraventricular tachycardia, or if it's a wide QRS, it is usually unstable and ventricular or supraventricular tachycardia. Another algorithm you can go by is a tachycardia. You find a narrow QRS, you look at the AV conduction. If it is 1:1, it is AV reentrant or AV nodal reentrant tachycardia. And you do is give adenosine will be reverted. If it is more than 1:1 conduction from atria to ventricle, it is likely to be an atrial tachycardia. If it's irregular, it's atrial fibrillation. If it's regular, it is likely to be a regular atrial waves. Then you have an atrial flutter. And a variable atrial rate, you have an EAT. In the case of wide QRS, could be either a 1:1 conduction could be an VT with SVT with aberrancy, or a less than 1:1 conduction from the atria to the ventricle. It's most likely to be a ventricular tachycardia. Just one or two slides more, then we'll finish off. Here is another 1-year-old, again stable hemodynamics, a structurally normal heart. You find a wide QRS tachycardia here, but since the patient is quite stable, you can again, it's more likely, as I said, it's likely to be SVT more often in the pediatric age group. I tried giving adenosine, baby. You can see that within the DD will be either is a ventricular tachycardia or SVT with bundle branch block. With adenosine, you can see it's immediately get reverted. So it is likely to be you can see the ECG normal sinus rhythm with ECG after that. So it was a quite stable. One last case here is a 6-year-old kid presented elsewhere in a pediatric OPD with edema and facial puffiness of 2 days duration. Was referred to our hospital with probably suspecting of nephrotic syndrome. Here immediately a pediatrician referred here with finding the tachycardia. Heart rate was around 240. BP was okay, around 90/60 with echo showing severe LV dysfunction and at PF1 and tiny PD. This was ECG taken. If you look at it again, I'm going a bit faster here. We can see here is a regular tachycardia with a rate of around 240 to 250. The QRS duration for a pediatric age group is around 100, 110, more than 100, nearly 110 is the QRS duration. So it's probably wide for a pediatric age group. Probably adult, you would have probably not really fit into the criteria of 120. This is closing on 120. Especially in the lead 2, you can see the wider QRS. So I thought whether it could be a SVT with aberrancy or not. So the possibilities are here are regular tachycardia with a wide QRS with a duration of nearly 120 millisecond, axis of left axis deviation with right bundle branch block. So you should think about VT versus SVT with bundle branch block, which we thought of, like I said, I had a word with Dr. Ajit. We thought we'd give an adenosine. When you look at it, took a leads, you can see, if you look at closely, I thought there was a retrograde conduction. I thought it could be SVT only because I thought some probably P waves coming next to the QRS regularly. So I thought of giving an adenosine. Adenosine was given, and this is an ECG of adenosine. If you look at carefully, you can see I just zoomed it here. Before adenosine, this is the retrograde. I mean, you see a P waves here, but on adenosine, the P waves disappear. Because of AV block, the retrograde VA conduction is abolished, and then this confirms a ventricular tachycardia. So AV was given diltiazem and then reverted. And I think Dr. Ajit will go into the details of any treatment on this. I think I'll probably stop here. Conclude, the most tachyarrhythmias in the pediatric age group can be tackled medically. Almost always get a 12-lead ECG or a 6-lead ECG before and after the procedure of dealing with the tachycardia. Unless it's emergency, try to get a diagnosis before treatment. Thank you.
Thank you, Dr. Edwin. That was an excellent presentation. I hope you have made it clear that the presentations that you expect, it's only checking the heart rate or anything else.
Pardon? Yeah.
Are you always dependent on just the heart rate for the pediatricians to confirm that it is a abnormal
thing? And the OPD, this OPD patient comes in. If a heart rate is abnormal, that's the first step you go in. If it comes to the emergency room or in a admitted patient, is fine. You're looking and everybody puts in a monitor. But in OPD, it may be an initial 24 hours patient may be quite stable. You may completely miss tachycardia. So at least make sure you record a definite heart rate in an OPD when you are like doubtful about it. It might missed completely, because this previous case also, like the VT I told you, they had gone to another pediatrician, probably they thought this puffiness came in. So that 6-year-old 220, 230 heart rate could not be missed probably. So just need to be careful about that. Some patients.
Why did the other pediatricians think it was a nephrotic?
Yeah, but yeah, it was probably thought as nephrotic and referred because it no other complaints except for edema, initial puffiness and edema. Usually puffiness is not a usual sign, but then this kid had a facial puffiness. You don't know why. So it was seen by someone and then referred to us to on a holiday. Next day the baby came.
What would have happened if that child was not diagnosed at that time?
He would have probably died, because by the time I saw him, even if his echo was very bad, it's severe LV dysfunction. My colleague here, the pediatrician, was quite concerned. Probably we thought, well, put a central line, ventilate him or not. I thought we can wait and see what's happening here, because I would keep everything ready. Another thing is, when you're managing, keep your defibrillator, everything ready. Be ready for, because if you're not seeing the echo, you may not have understood the significance. But the heart was hardly contracting. So the tachycardia was going on for more than 24 to probably more than that. So it's at a severe LV dysfunction. Probably another few more hours, they would have just collapsed and died.
Very good case. Thank you so much. It was great that your pediatricians picked up this case. Thank you, Dr. Edwin. Now we'll go on to the Dr. Zulfi. Dr. Zulfikar, can you share your slides?
Yeah, I'll try. Jason, I might need your help also. Let's see. No, what I'm saying is.
No, you just put a share slide. I hope you have your.
Yes.
You have your presentation on the desktop, isn't it?
Yes.
It's open. It's open.
Open.
Yeah. Now, Dr. Zulfikar doesn't require any introduction. He's a great teacher, and everyone is waiting to listen to him all the time. He presents everything so simply as Dr. Edwin had done so far. It's great to have Dr. Zulfikar on our panel. He's been a contributor to the IEP drug formulary. Whenever we want him, he's there for us. Have any problems sharing the slide?
Yeah, there is some problems there. 1 minute.
Have you opened your PowerPoint on the? Yeah, you got it. Yeah.
No, I got it. Now, what do I do? Share screen.
Yeah.
Share screen. Yeah.
You click on your PowerPoint.
Jason Tachy final I have written. Yeah. Double click or a single click?
Yeah, double click. No.
Share screening has start. The window selected is invalid. What is that?
It's on your desktop, isn't it? You haven't sent it to me, no?
No, I not send it to you. It's on the desktop. So how do I go back to the desktop? What I did was share this thing, and there is where is the screen? Basic files. Chat. Jason, I have a white background, this thing, or which nothing much is seen. Only screen is seen, and then
No, your desktop come on when you share your slide.
no,
Desktop comes on.
no.
Is your PowerPoint on the desktop?
Yes, this.
It's on the desktop. So
Desktop.
when you press on share slide, you you should see your desktop.
Suppose it's in the documents, what will happen?
It has to be on your desktop.
I think I transferred to desktop, but I am not seeing anything.
When you just
can I enter full screen and then see? No.
Otherwise, just send it over to Pramod.
Okay. Now, right?
Yeah, I got it.
Huh?
Got it. Now it's coming on. There's something coming on.
I see.
Started sharing.
Then I will.
Sure.
Yeah. Now put that murmur IAP zoom. What is your decent tachycardia? Press on that. The decent tachycardia.
I don't see the decent tachycardia here. Where is it?
I can see
Next
it here.
about-
Wait.
This is like Houston and Discovery. You have to, by long distance, control me. Should I?
I can see your.
Yeah, on the left side, second row, there is this decent tachycardia is there.
We can see your.
Side, second
I can
row.
see your.
No, I don't see anything. That is. Decent is there. Decent.
Decent tachy is there. Yeah,
we can
go
see
below,
your
sir,
decent
there is-
tachy.
Decent tachy is there on the left side.
I see.
Sir, but on your screen, what is happening?
You minus it.
I can see myself. I can see Edwin. I can see also Pramod. Then Jason, blank, and chat, home, meeting. Nothing more.
So on your screen,
And you are saying you are screen sharing. That's all I can see. There is no PowerPoint.
No,
Then
no.
there is one called
You minimize zoom. Minimize zoom.
Minimize zoom. Okay.
Now do you see your PowerPoint, your screen?
Now desktop I can see.
Yeah, then now click on your, now you're going there, down. Yeah, click on the tachy.
decent tachy.
Yes,
Yeah,
yes.
that's it. Now you got there. Now click on that.
Yeah.
Yeah, let it open. See, it should have been open before the talk started. You should have kept it open.
No, now it's okay, sir.
It's opening.
I know it's opening. This is even worse than Armstrong taking baby steps into the surface of the moon.
Yeah. Now it's open. This should have been open. This should have been
Yes.
opened before you. Should have been
I'm-
opened on your desktop.
Yeah. Something is happening here. PowerPoint. No.
Yeah.
Let's see. But it's very slow, isn't it? I'm so sorry for my lack of competence in this opening decent tachy. Yeah, I think.
Zulfi, you don't have to feel sorry, because now the people who are interested in learning Zoom would have learnt it by now. So
Yes.
there is a positive to this.
This
Also,
is
like arrhythmias, it has to be made really easy.
Thomas Alva Edison. Right. And you get a bulb. Why is it not opening anyway?
It's your computer. That's why it's not opening.
I see.
Something is wrong with your computer. That's why it's slowed down for some reason.
This is why you should have sent it to me.
I see. The problem was, Jason, for the last 3 days, I was stuck with one of my relatives.
I know.
So I was almost thinking of not joining. But with Jason, how can I refuse? Like you are like Godfather, no?
Oh,
When
God.
you, and then what I'm saying is, like Godfather, he says he will make an offer and you can't refuse that. But nothing is happening, Jason. Processing. What is it? Processing now? Kya ho gaya?
No, I think
No.
you're there.
Yeah,
You
now it's
go.
come on.
Ah, yes. Now what?
Awesome.
Now I feel comfortable.
Now, yeah, make it full screen.
Full screen. Yes, yes, of course.
Yeah. Okay, now
back to business. Yeah, I think we have 7:45 already. Anyway, this is basically Marlowe saying in Dr. Foster's Run Slowly, the horses of night. That is what tachyarrhythmia do. And we will have basically pharmacological therapy of tachyarrhythmia to reset the cardiovascular clock. And KK and Edwin have already unlocked the arrhythmias by history, physical findings, and electrocardiography. And tonight, I think basically we will have a conversation on treatment of primarily SVT and fetal SVT. And if the time permits, which is less likely, I suppose, we will have some discussion on VT also. And as Shelley says, it basically what we want to is to break the SVT, which Edwin has already demonstrated. He has also said that majority of the SVTs are either AVRT or AVNRT. Don't get upset by this terminology. It's a very simple. AV re-entrant means accessory pathway. AV nodal means there is some problem with the AV node. And ectopic atrial tachycardia, standard ectopic atrial tachycardia. Less is not a thing. And basically, we will be primarily discussing the acute management and prophylactic management of SVT, transplacental management and the postnatal management, and maybe we'll look at the VT. This is basically the regular algorithm which we generally go for a management of SVT, as Arjun has already demonstrated. If the baby is unstable, naturally you have to decivert, and if the baby is stable, we'll try vagal maneuvers while loading adenosine, because don't waste time. We try a vagal maneuver and somebody else will load the adenosine, and then try. If it is not successful, we can either choose amiodarone or diltiazem. If it is still refractory, there is no harm in giving another adenosine, or maybe then we will think of again amiodarone, and later on maybe flecainide if it is available. Right now, I don't think it's available. And the vagal maneuver, probably the only safe vagal maneuver in an infant would be an ice back application, as we have learned, while cellular maneuver can be attempted in an older child. And very importantly, rather than saying what to do and what not to do is important in pediatrics. That is no eyeball compression and absolutely no carotid massage, especially in a small child. And the adenosine administration, I think, as I again reinstate whatever Edwin has said, probably for a pediatrician, for a small baby, probably the most proximal vein would be an antecubital vein. You will have a cannula, at least 2 people. No withdrawing blood into the syringe, because the RBCs will destroy the adenosine, and the rapid saline chase. I think that's very key, because you need at least 5 ml in an infant, 10 ml in a child, and maybe 15 to 20 ml in an adult, because it has to cover whatever distance from the antecubital vein to the right atrium. And this is the graphic picture of how to do that. Basically, we start with 100 microgram per kg, then wait for 2 or 3 minutes, and then, because the half-life is so ultra short, we give another 200 microgram per kg, and we can go up to 300 microgram per kg, and of course monitor scope and keep everything ready, including a defibrillator. And basically, you should remember that for a 10 kilogram child, for a 1 full administration, you might need at least 2 ampules. So be practical about this. Keep at least 2 ampules, so that this 2 ampule will be absolutely needed for 3 doses. 100 microgram goes to 200 and 300. These are the ways of conserving adenosine rather than giving 150 and all. And the success rate is very good, especially for an accessory pathway, almost 95%. And sometimes we generally, in the beginning, in our learning curve, we used to have failure to respond to adenosine, basically because of a slow push and, very importantly, not enough saline flush. And of course, as Edwin was demonstrated, adenosine non-responsive SVT can also be there. And also the overall sympathetic stimulation may be there in a baby. So you may have to give a little bit of sedation. And amiodarone is another drug which we use to convert SVT into sinus rhythm. A bit slow, but I think in our, at least in our center, this is the second choice after adenosine for an SVT, because it is very versatile and it's very most effective, and it's also relatively safe with the presence of a congenital heart disease and heart failure. But the problem is only on long term, which we will discuss a little later. And esmolol, I think we have tried, but basically we have been comfortable with either adenosine or amiodarone. Verapamil, we have something more to say, and procainamide is also there. Digoxin as a single agent is not very effective in an acute termination. Again, beta blockers are very versatile. It can manage SVT of a regular variety, ectopical tachycardia, and it can even manage a catecholaminergic VT, which is rather uncommon in pediatric practice. And this is a very practical point which every pediatrician neonatologist should know, that IV verapamil is absolutely contraindicated in the newborn infants below 1 year at least, and with significant heart failure. Very, very practical thing to know. And ectopical tachycardia, I think it's difficult to choose. Probably the first choice is IV amiodarone. Second options may be a beta blocker or IV flecainide. And after conversion, the question is, sorry, if there is no conversion, what do you do? Use a DC version. So the indication would be, of course, initial shock or hypertension, as Edwin has said, a decompensation of the heart and a non-responsive to the standard therapy. You have to give a synchronized DC version. And neonatal SVT, I think, again, the preferred drug is IV adenosine, and flecainide is available, and amiodarone we have given, and we have been so far comfortable in converting neonate into a sinus rhythm. And sometimes you need a DC version also, and absolutely no IV or verapamil. So the absolute no in an SVT in a child would be verapamil below 1 year. Vagal maneuver in the newborn, I think probably not to do that. A combination of a beta blocker and a calcium channel blocker together. Digoxin as a single agent. These are some of the factors. And there is a big data from in 2015, so a large number of babies were treated with acute SVT was treated, and the drugs used are basically the same, which we have discussed: adenosine, amiodarone, esmolol, flecainide, and procainamide. And what after conversion you have to take an ECG, because as Edwin showed you, you should realize that it is a sinus rhythm, and also you look for an accessory, a visible accessory, what we call as a pre-excitation, and decide on a preventive therapy. The point is the what you call as a chemoprophylaxis, I could say, is age dependent. For example, if you have an SVT below 1 year, I think some of them will go away. So there is a scope for an expectant therapy, but some of us prefer to be a little safe and give a drug prophylaxis. Between 1 and 5 years and beyond 1 year, the chances of this problem going away is less. So we may have to depend more on drug prophylaxis, and also more on the handsome young gentleman who will come after me. That's it. So the natural history of SVT is that nearly half of them will resolve by 1 year, and less resolve in the age group of beyond 5 years. So you have to plan accordingly. So in a young baby, there is still scope for an expectant policy. And if at all we give a drug, you can give it for 6 to 12 months. The usual safe drug which we use is a propranolol or atenolol beta blocker, and not to use digoxin and sometimes verapamil also if you have a WPW syndrome. And beyond 1 year, the growing out phenomenon is less. So think of a long-term strategy. Basically, you plan a two-pronged thing. That is, you start with a drug and then wait till around 5 years, and the weight is okay, and the electrophysiology is comfortable, and the child is not comfortable because child is okay. I think there is probably no need for an invasive therapy. And beyond 5 years, again, one could try the pill in the pocket. You can combine diltiazem and propranolol and teach the high schooler that if you have this SVT, you can take it and sometimes it will revert. And of course, we may have to depend upon chronic prophylaxis. Here, I think possibly, as Anil would tell you, the invasive aspect will come a little more and the threshold will be a little less in an older child or adolescent. So basically the long-term strategy for an SVT below 1 year is primarily dependent on drugs. Some people would go for an expectant therapy, one episode, brief episode, no heart disease, whereas 1 to 5 years would be mainly drugs. Expectant therapy is less likely to be used, and of course plan for a RFA beyond the age of 5 years. I'm not sure whether this 5 year as business has become changed, which we will see. And the practical thing for a pediatrician is that the home care, how to prevent and detect recurrence, because adequate suppression has to be given. The dose has to be reasonably good, minimum 2 to 4 milligram per kg, because they tolerate propranolol very well. And the second choice would be in our hospital. Many times we, especially in Kerala, basically the educational quality is very good for female of the species. They are probably more educated than their husbands generally, and sometimes we give them pulse oximeter to see and tell them that the rate is very fast, like 150, 200. Think there is a possibility of tachycardia. Some mothers are also very comfortable with a simple low-cost stethoscope. We teach them how to, especially in the newborn baby, because it's very difficult to put a small pulse oximeter in a newborn baby. So what we do in the newborn baby with an SVT is to teach the mother to use a stethoscope and look for, if she cannot count the heart rate, and that has to be most likely a supraventricular tachycardia, and possibly 6 months, as I told you, from 6 months to 1 year. Generally, we play safe, give for 1 year and then taper slowly and look for a breakthrough SVT. And I think this is basically the same again. Then fetal SVT, I'll take 3 or 4 minutes. The diagnosis is by fetal echocardiography with a Doppler, and you decide whether fetal height drops is not present or not present, and of course the gestational age, because if it is near term, it is always better to treat postnatally, induce labor and treat post, easier to do, whereas if it is not near term, I think you need to give a pharmacological termination of a supraventricular tachycardia in the newborn. The preferred drugs is digoxin is one agent which I think somehow digoxin still stays put in this particular category. Majority of the cardiologists have left lurching, whereas second would be flecainide. So one way of looking at fetal SVT, decide whether there is heart failure or not. If there is heart failure, you can comfortably start with a peroral digoxin in a slightly larger dose for 3 days, wait. If it is not there, increase the dose to 2 tablets 2 times for 3 days. If there is no response, adding flecainide. And suppose the baby has what you call as a high drops or a heart failure, you can choose either an digoxin, but majority of us go take a risk and go for an oral flecainide and maybe add digoxin. So these 2 drugs are perhaps the best drugs for a fetal supraventricular tachycardia. And you must remember that the mean time for converting it into sinus rhythm is around 5 days. So you don't expect a miracle in 1 day or so. So it can range from 0 to 14. It's very important. But majority would, of course, convert within 1 week or so. And there is a big systematic review possibly showing that flecainide may be superior in converting, both with high drops or without high drops, and both have similar side effects also. So it has, as of now, maybe a little edge on digoxin as a therapy. And I think specific areas of concern, which I think the pediatric community should know, is that IV verapamil is absolutely contraindicated in infants. even though very safe, adequate precautions has to be taken while giving adenosine, including having a defibrillator in the ICU. And except for the toxin is no longer a flavor of the month or a year also. And the choice of prophylactic drugs in SVT primarily depends on the presence of a WPW syndrome, because you have to choose a particular drug like beta blocker for WPW. And a treatment strategy differs for SVT below 1 year, 1 to 5 year, and beyond 5 year. And post-conversion therapy in SVT could be expected also. Basically, so far I have not been brave enough to go for what call as an expectant therapy. I would, of course, would like to have input from all three of you during this discussion. And then there have been some talks of a use of Fibrillation in children with the tachycardia needs a further experience in pediatric practice. Avoid all anti-arrhythmic drugs in the first trimester as far as possible. That is why I put an asterisk. But beta blockers, flecainide and verapamil may be given in the second and third trimester if the lady has been on an anti-arrhythmic agent. And so we have possibly tried to demystify arrhythmias in kids, hopefully. And case-based recognition and definition has been done by Edwin, and managed option have been maybe a little fast because we started a little late. And the preventive therapy and a cure concept and practice has been discussed. And the question is, can we achieve a cure for tachyarrhythmia? As Obama says, yes, we can. And our next speaker, as John the Baptist said about Christ, is a better person than us to talk to you on the potential for cure. And he's perhaps almost as handsome as Obama, or is it me wrong? So I'll be glad to answer any questions from Jason or my colleagues in pediatrics. And thank you very much for your kindness and being patient, Jason, for my inadequacies in what you call as technology. Thank you.
Thank you so much, Dr. Zulfikar. Now, unshare. Remove unshare.
Yeah.
Unshare so that.
Where do I do that?
On the top itself, where you shared, there is an unshare.
I finished that.
Stop sharing. Stop sharing.
Stop sharing. Yeah. Thank you.
Just click on that.
Yeah.
Yes.
Thank you.
So, yeah, thank you so much, Dr. Zulfikar. Now we're going to go on to the next presentation, and that's going to be by Dr. Ajit Tachil. Please share your slides, Ajit.
So,
Ajit Tachil is going to talk on the invasive management. Yeah, make that a full screen. Ajit Tachil is going to talk on the invasive management of pediatric arrhythmias, and he is again from the Lissi Hospital, Kochi. Your next slide is your, I hope, is your biodata slide. Next slide, please. Yeah. Yes. Have a next slide.
Yeah.
Yes. That's the handsome man that Zulfikar was talking about. Both Edwin and Ajit are handsome young boys. Now, he did his cardiology from All Institute of Medical Sciences, and his did his postgrad doctorate fellowship in at the Care Hospital, Hyderabad, immediate post DM, and has been practicing exclusively in the field of cardiac EP would be
electrophysiology.
And
Sorry.
And he's performed more than 2,000 ablations and 2,000 implants. That's a huge number of. That's why we've been selecting. We sort of handpicked him for doing this talk for us. Section editor of the Indian Pacing and Electrophysiology Journal, and a member of the test writing committee of the International Board of the Heart Rhythm Examiners. And he's going to tell you about all the latest things about what you can do for these children with tachyarrhythmias. Over to you, Dr. Ajit.
So thank you, everyone. Thank you, Dr. Jason, and especially to Zulfikar sir for the comments. So let's get straight to what I want to say. It's about invasive management of pediatric tachyarrhythmia. I would like to discuss 4 points. Why do we need invasive management? How do we do it? And when is the right time to consider invasive management, and what are the expected outcomes? So why do we need invasive management? Number 1 point, some tachycardias just may not be controlled with medicines. It will just keep on recurring with medicines, or you just can't control it with medicine. Then at that point, obviously, some tachycardias can potentially cause sudden death. So in a tachycardia which can potentially cause sudden death, medicines may not be enough. You need to put in one more option which makes the baby's life or the child's life a little more safe. And the third and most important point of why we need invasive management is that, look, medicines do not cure tachycardia. They only control them. So long as the child is taking the medicine, the tachycardia is under control. And for many obvious reasons, lifelong medical therapy is undesirable in a child. So these are the 3 reasons why we are talking about invasive management. So the next question, what are the options that we have for invasive management? I will briefly give examples of what all options are available. So I'll talk a little bit about all of these options. The first and most commonly used option is radiofrequency ablation, which is sometimes used in conjunction with a technology called 3D mapping. There is also cryoablation, which is not available in India. Cardiac sympathetic denervation is another option which is unfortunately underutilized. There is the option of implantable cardioverter defibrillator and automatic shocking machine, which is usually not used in pediatrics for some reasons, which I'll mention. And I'd also like to talk about a couple of invasive diagnostic options, which is the electrophysiology study and the implantable loop record. So first one, the most important point here is that most children have normal hearts. Most children with arrhythmias have normal hearts, unlike adults. And in normal hearts, at least, most arrhythmias originate from a discrete area in the heart. And now, if we could find that discrete area and target only that discrete substrate responsible for the arrhythmia, we could cure it. That's a lifetime cure without any medicine, which is a great end result, if we can do it. Now, in EP, what we do is, we all know that we take the ECG, and the ECG represents the activation of the whole heart. For example, the P wave represents the activation of the whole atrium, or the QRS represents the activation of the whole ventricle. But when we take an ECG in the EP lab or the electrophysiology lab, we take local intracardiac ECGs. That is, we put all these catheters, which range all the way from 4 French to 7 French. That is just 2 millimeter to 3 millimeters in diameter. And then we touch them point by point, and we can take the ECG of only this point, or the ECG of only this point. So these are local intracardiac ECGs. Why do we record these local intracardiac ECGs? Because by analyzing the local intracardiac ECG, we can pinpoint the location of the abnormal anatomical substrate that is responsible for the arrhythmia. So it just starts from one point. They look like these local intracardiac ECGs look like these. If you're not used to it, it doesn't make any sense to you. But for people who are used to it, it makes perfect sense. For example, in this particular patient, the arrhythmia is starting from this particular point. But once we identify that the arrhythmia is starting from one single discrete point, we can get rid of that point. How do we do? The most common way of doing it is by RFA, or radiofrequency ablation. So this catheter is now on the mitral annulus across the intraatrial septum. This catheter is somewhere near the ostium or the coronary sinus. And we get to heat only this particular spot, okay? And it's just that spot, and it's a very controlled heating. It's about 70 to 80 degrees tissue temperature. And we heat it for anywhere between 20 to 120 seconds, depending on what we want. And the depth the heat penetrates can be controlled anywhere between 2 millimeters to 8 millimeters. The diameter of the heated area can be controlled anywhere between 4 to 8 mm. So it's basically very, very controlled heating of only one spot. So that is basically what radiofrequency ablation is. Now, radiofrequency ablation is usually done with X-ray guidance. Not a great thing to do in children, because some of the procedures will get over quickly. Quickly means about 45 minutes to 1 hour. Some of the procedures can go on for a long, long time. It's not a great idea to use X-rays in children for such a long time. So in most ablations in children, the preferred method is to use what is called a 3D map. A 3D map is nothing but a live virtual cardiac image which is created, and the electrical signals are superimposed on this image. This gives rise to the same or even greater accuracy with minimal use of X-rays. For example, this is the image of the left atrium of a child, and these electrical signals can tell the experienced operator that the problem is at this spot. So you just heat that spot and it's gone. So that is 3D mapping, which is basically an additional software to conventional X-ray guided radiofrequency ablation to minimize use of X-rays and increase the accuracy in some cases. It can also be done by cryoablation. Instead of heating to 70 to 80 degrees, you freeze a particular spot, like in this case, this particular spot, to minus 70 to minus 80 degrees. It is done just like radiofrequency ablation in the cath lab. Cryoablation is not available in India, so I won't be talking about it more. Now, the third thing which we must not forget when talking about arrhythmias is this. Now, this is a picture of the heart, which is richly innervated. So these are the sympathetic and parasympathetic plexi of the heart. You can see that the heart is virtually covered with nerves from the outside. And what do these nerves do? These nerves are the nerves that supply the sympathetic and parasympathetic inputs to the heart. And those inputs obviously come from the brain, then go to the stellate ganglion and the upper fourth thoracic ganglion. And from those ganglia, single nerve fibers come out and they make these cardiac sympathetic and parasympathetic ganglia. Now, one of the ways of controlling life-threatening ventricular arrhythmia is what is called neuraxial modulation. Neuraxial modulation basically means you modulate the sympathetic traffic through these neurons. And this can be done by denervating the lower stellate ganglion, the lower part of the stellate ganglion, the lower two-thirds of the stellate ganglion, and the upper, that's the first to fourth thoracic ganglion. This can be done in two ways. So this is one way of doing it. This is using a video-assisted thoracoscopy. So this is the entire chain being pulled up. That's the T1 to T4 chain being pulled up, and it can be cut off along with the lower two-thirds of the stellate ganglion up to the upper fourth of the thoracic ganglion. This is feasible. The advantage of this is a percutaneous keyhole procedure. This can be done in older children, let's say age 10 years or more than 10 years. But in younger children, this is done by left thoracotomy. Most pediatric surgeons who work on the aorta are very familiar with doing a left thoracotomy, and this is a relatively simple procedure. So this is another option. Now, yet another option, which is less commonly used in children, is the ICD, or the implantable cardioverter defibrillator. It's something like a pacemaker. It's put under the skin normally, and there are these wires going in. Unlike a pacemaker, what it does is it automatically detects ventricular fibrillation and shocks it to sinus rhythm. So if you have a child who, for some reason, for example, Brugada syndrome or some types of long QT syndrome, who are prone for sudden death due to ventricular fibrillation, this would be a good option. But the problem is these ICDs are big, bulky devices, and children don't have the amount of space in their chest for them. So putting a pediatric ICD is quite a job. You have to do a thoracotomy, open up the chest, and get this wire is stitched to the posterior part of the heart. This wire is behind the heart. These are on the atrium. So it's a big thing. And every time you need to change it, it will last for about 8 or 10 years. After that, it needs to be changed. Then you need to open up all over again. So even though ICD is a great option to prevent ventricular death due to ventricular fibrillation, in children, they're probably not such great options. And the last thing that I want to talk about in diagnostic thing is some kids have very infrequent arrhythmia, and you cannot induce that arrhythmia in the EP lab also. Then you have this option called the implantable. Well, rather it should be called the injectable loop recorder, which is something injected under the skin and just left there. And it can give you fantastic ECGs like this. It can record ECGs for 3 years. So these are the tools available. We have all these guns. Which poor little kids do we target to shoot now? Okay. I didn't mind it literally. I didn't mean that literally. But anyway, I'll take you through 3 examples. The first obvious choice is when you cannot control it medically. So this is an 18-month-old child with incessant tachycardia, not terminating with adenosine or beta blocker or amiodarone or even cardioversion. She has severe biventricular dysfunction. She's an inotrope. She's on ventilator support. She's probably got 2 or 3 more days to live. She's going to die if we don't control this tachycardia. So this was a tachycardia, and this was an accessory pathway. It was a right posterior accessory pathway. It was ablated right here. It was one of the most gratifying procedures I've ever done in my life. One lesion, this thing is gone. And this is it after the ablation. The child took about 1 week to recover. After a month, her LV is normal. She came for follow-up recently, I think about 2 or 3 years after ablation. No drugs, completely normal child, nothing more gratifying. This is another situation where you don't even try medical control. Okay, so this is a 14-year-old child after TAPVC repair who's in incessant atrial flutter. Her LV function, RV function is normal, but she has incessant palpitation. This is a heart rate when she's at rest taking an ECG. When she's moving about, her heart rate shoots up so much. Now, in a structurally abnormal heart, like a post-TAPVC repair, it's virtually futile to try medical therapy to get rid of atrial. So this was what it was. She had 2 loops of atrial flutter. These are all pictures of the right atrium. This is just for representation to saying that sometimes it can be complicated. There's one loop going around the tricuspid annulus, one loop going around the posterior part of the right atrium. So multiple lesions are required in this part of the right atrium, in the floor of the right atrium, and this part in the posterior wall of the right atrium. At the end of it, she is in sinus rhythm. Now, next option. For some reason, not keen for medical therapy. For example, this is a 13-year-old boy who has frequent palpitation and pre-syncope, and she has mild LV dysfunction, which is what is called PVC cardiomyopathy. Frequent PVCs can cause LV dysfunction. You can see at every alternate beat is a ventricular premature beat. And because of the age, the parents asked, is there a permanent cure? They said, I told there's a permanent cure. They said, if there's a permanent cure, we'd like to go for that straight away. So we went for a permanent cure. These PVCs are coming from the left coronary cusp, just under the left main coronary artery. So this orange nub is the left main coronary artery. This is a 3D picture. You can see that the PVCs disappear while being ablated. So this is ablation going on. If you look at it lower panel, initially there are a lot of PVCs happening. All these irregular beats are PVCs. And then towards the end of a few seconds of ablation, the PVCs are gone. It's sinus rhythm. This is actually fairly close to the left main coronary artery, just 10 millimeters away from the left main coronary artery, but 10 mm is actually a very, very safe. And the third option therapy may be too dangerous. It's a 4-year-old child with long QT syndrome, and you can see that the QTC is about 520 despite beta blockers, and he gets short episodes of polymorphic QT. Now the question is, should he get an ICD or should he get a left cardiac sympathetic denervation? I think in a 4-year-old child, I'm very clear the first option is left cardiac sympathetic denervation rather than ICD. There are 2 opinions regarding this, but I think I'm very clear that the option is a left cardiac sympathetic denervation. And after sympathectomy, his QTC is 450 milliseconds. He's still on beta blockers, but so far no events. Now coming back to that case that Edwin presented, this was a ventricular tachycardia, beautifully demonstrated because adenosine stopped the VA conduction, but did not stop the tachycardia. Relatively narrow QRS ventricular tachycardia that comes only from the vesicles. See, the vesicles in the heart are what causes rapid conduction. So if you have a ventricular tachycardia starting from the vesicles, you have a narrow QRS ventricular tachycardia. It has a typical shape of RBBB morphology in V1, right bundle morphology, and a superior axis. It could be very easily ablated. Now, in this case, we tried cardioversion because child had LV dysfunction. It was not successful. Now what to do? Now, from the morphology of this tachycardia, because it was right bundle and superior axis, we are quite sure this is left posterior vesicular VT, and vesicular VT is exquisitely sensitive to calcium channel blockers. So she was given IV diltiazem and she attained sinus rhythm. Ejection fraction became normal in 2 to 3 days. Now what? Ablate or put her on medical therapy? So this is what we did. We gave diltiazem. We gave diltiazem 30 milligram twice daily, taught the mother to count the heartbeat like Zulfikar said mentioned previously, and advised do ablation if and when there is a recurrence, not right now. I'll explain why. Now, even though ablation has excellent expected outcomes, about 90 to 99% success in most of the cases, and a recurrence rate of only about 1 to 10% in most of the cases. And in most cases, you can stop medical therapy after ablation. This child was not advised ablation. Why? This is why. there are some special points which you should keep in mind in pediatric ablation. Number one point, many arrhythmias do not recur for months to years if managed medically, which means that you can buy time, months to years of time by managing medically. Point number two, for a good ablation endpoint, most arrhythmias should be induced in the EP lab. Point number three, most arrhythmias cannot be induced under deep sedation or general anesthesia, and many children need deep sedation or general anesthesia. So if at all I can postpone an ablation, I would like to postpone it, because when I do an ablation, we want the arrhythmia to be inducible in the lab without sedation. And like Zulfikar sir said previously, most SVTs will not resolve beyond 6 years of age. So beyond 6 years, the only question is when to ablate rather than whether to ablate. But in when to ablate, I would see, if possible, I would wait till the child can cooperate with only mild sedation. And finally, most will need ablation, like I said. There are some arrhythmias which do not need sedation. Some arrhythmias which do not need to be induced for a successful ablation. So this is one of them. This is an accessory pathway, a manifest accessory pathway. So this child was 8 years old. This was done under general anesthesia. It was comfortable for the child. So in a case which does not need general anesthesia or sedation, I would do it as early as feasible after the age of 6. But in a case which needs general anesthesia or sedation, where I'm worried that the tachycardia may not be inducible under general anesthesia and sedation, if I think it is not life-threatening to wait, like in the case of ventricular tachycardia, I would like to wait. Thank you for your attention, and I'll be happy to clarify any questions which I could.
Thank you, Dr. Ajit. You've taken us to dizzy heights of EP, and it's a very good presentation. I'd now request Dr. Krishna Kumar to give a summing up, and then Dr. Zulfikar to sum up after Dr. Krishna Kumar.
I think Dr. Zulfikar can sum up to save some time. I'll focus on the quiz.
Okay. No, nothing much to sum up. One or two questions I want to ask to especially Tachil. See, there's a usual question when you have a WPW syndrome in a young child, and he has hardly any recurrence and he's on a beta blocker. And after some time, the parents will ask you, when can you stop the chronic, what do you call as prophylaxis therapy? So what is your take on that?
So what I usually do is this, if the initial arrhythmia has not been life-threatening, usually it is not life-threatening, I stop it after about 6 months to 1 year. And I tell them, I tell them, look, are you ready for an ablation if a recurrence occurs? If they're ready for an ablation, if recurrence occurs, I tell them, go ahead, stop it. It's not a life-threatening arrhythmia. When it comes, we'll give adenosine, then we'll ablate. So after 6 months to 1 year, I usually don't keep children or adults on long-term medical therapy.
And wait possibly, and if they do not, well and good. Otherwise, go for an ablation, because by the time the child is old enough to be, managed.
Right.
Okay, I have a question to Dr. Edwin.
Yes.
It's from Dr. Rekha Sakriya. Now, she said that what is the role of Holter monitoring in arrhythmias? One, and then she's asked if you have a relatively stable child and they comes to you saying that there is a history of palpitation and there's nothing at that point of time when the pediatrician sees the child, how do we pick up a case where there is no arrhythmia? I mean, she's had an palpitation earlier. What do we do for those children?
Basically, if you Holter is when you have a history of a clear history will be the only thing we will have it, because if you don't have an ECG, you take a baseline ECG, assume it is normal. If it is WPW syndrome, anything, then we can deal it accordingly. Majority of the time, what happens is they might give us a clear history of palpitations, but there is no documentation. That's a problem. So then a Holter may help us in identifying the tachycardia. Holter gives you a 24-hour recording, and we ask them to record if there's any palpitation during the recording period. And now we have the ELR or a loop recorder, which can take the ELR records for 2 or 3 days, or loop recorder can go weeks. So then if you are doubtful, you have to have a diagnosis. We have to have these modalities to identify the tachycardia, then treat accordingly.
What do we do to these children who don't have a problem at the time that they see the pediatrician? They said there is a history.
Yeah, you only have to go by the history alone. If you clearly take an history, if you can identify there is a clear possibility of palpitation which goes on and off. Majority of the SVTs, as we discussed, which will be on and off phenomenon. It may last for a short period. So patient gets a feeling of uneasiness, dizziness. So if you have a clear history, we try to identify the tachycardia. I mean, the only way, another way I tell them, you go and get an ECG done immediately, the closest place you can get it. By the time it may last for only 10 minutes, 15 minutes. So you don't come all the way to the hospital, but identify the closest place we can get an ECG done. Take an ECG, then go to the pediatrician or wherever.
Dr. Zulfikar, the question to you is, most useful drug for SVT at any age is adenosine. Why is it not used in fetal SVT?
Yeah, this was actually, it's an interesting, we would say that it's a very simple question, but I think it's a very interesting question asked by postgraduates. So the simple reason is that it does not cross the placental barrier. So the only drugs which could cross the placental barrier and do not harm the baby would be digoxin and flecainide, and plus minus amiodarone and sotalol. But I would always prefer to give either digoxin or flecainide.
And is defibrillate an absolute must when we have, after given adenosine?
Yeah, I think so. I mean, I definitely feel so, because the usually adenosine, so far we have had no problem in the ICU in managing. Once in a while, we had some brady. Once in a while, even with a mild wheezer, usually nothing happens. But there is always a theoretical possibility that if we are dealing with an accessory pathway, especially the manifest accessory pathway, which we call as WPW syndrome, there can be a conduction from atrium to the ventricle, and it can have an atrial fibrillation developing and can cause death. So always safer to have a defibrillator.
Dr. Edwin, what are the conditions that may be unmasked with adenosine?
Yeah, basically, as we described, those conditions which are not involving the AV node. So those occurring above the AV node, which will be unmasked by adenosine. Adenosine causes AV block at the AV node. So those atrial tachycardias like a flutter or EAT will be unmasked, while the others, the reentrant tachycardias with the AV node involvement, will be terminated.
Dr. Ajit, a fantastic presentation. What is the age that you do radio ablation, and for SVT and VT?
We already
what is
mentioned
the ideal age?
SVT, wait till 6 years if you can wait. Beyond 6 years, infrequent episodes, wait till the child can cooperate with minimal sedation. I'd say if at all possible, I'd wait till about 12 or 14 years of age. If it's a manifest accessory pathway, I wouldn't wait that long. Manifest accessory pathway is a little more difficult to deal medically. Some of them can conduct very rapidly, and manifest accessory pathways can be done even under general anesthesia. So manifest accessory pathway at 6 years, I would just do it. Not a manifest accessory pathway, any SVT, I'd wait for as long as possible.
Now, when radiofrequency ablation was not available, what was the prognosis?
The prognosis of SVT?
No, yeah, SVT or VT without, when it was not available, we're not doing radiofrequency ablation, or the centers don't have the facility, what is the prognosis for the child?
Most SVTs are VT is different. We will not come to VT right now. They're two different things. Most SVTs don't kill. Very rare SVT like the one I presented there have incessant SVT. They have LV dysfunction. They go on to heart failure. Most of the SVT, the child will collapse, and the child, you'll get enough time to take the child to a hospital and do something. So it's not a life-threatening thing, but it's a very fearful thing every time it happens.
And what are the complications you have had with radiofrequency ablation?
I have not had any significant complications so far with radiofrequency ablation. That is because before we do the ablation, there are two things. We need to decide how aggressively we are going to ablate that particular child. This really depends on how difficult is it to control it medically, and what is the willingness of the child or the parents to take medicines. Now, what we need to understand clearly is that the risk of radiofrequency ablation is entirely controllable. There are risks of causing damage to the access vessels. There are risks of perforating the heart. There are risks of causing AV block by damaging the AV node. But virtually all these risks are almost fully controllable if the operator takes care. There'll be some situations where you know that you need to ablate a little bit more aggressively to get rid of the whole tachyarrhythmia. And if you ablate that much more aggressively, you might cause a problem. So you discuss that beforehand with the parents. And in general, for all children, I tell the parents, if I have to ablate this aggressively, I will stop at that point. I will not ablate aggressively in a child, because a child will grow up to around 18, 19 years. At that age, if I want, I can do it aggressively. I've done that for several children. Do a slightly less aggressive ablation when I feel that an aggressive ablation may be dangerous, and tell them, okay, it's okay. We've controlled the situation till 18, 19 years of age. At 18, 19, we can fix it. So never do an aggressive ablation in a child. And if we keep that in mind, we can get away without any complications.
How many times have you ablated a single patient?
Not more than twice. Some patients I've electively chosen to ablate at much older age. I've done one ablation at 12 or 13 years of age, and I found out that if I had to get a perfect result, I would be very aggressive. And all those situations I've discussed beforehand with the parent, not after coming onto the lab. And as per prior discussion, I've told them, I'm going to stop here. We'll ablate it later. And some of them I've ablated when they're about 18, 19 years of age.
Excellent. And one more question to you is, what is the cost?
Cost?
Yeah.
A standard ablation, I mean, there's a wide variation from center to center. In our center, a standard ablation would cost about maybe 45 to 50,000. And if I had to put in a 3D, it will cost about 85 to 90,000. Almost all pediatric ablations I prefer on the 3D because I feel guilty every time I plus the fluoropedal and the child is on table.
Excellent. Very good. We'll have some more discussions later, but now we'll go on to the quiz. And Dr. Krishna Kumar, can you take over?
Yes. Can you hear me?
Yes.
Yes.
Okay. Thank you all for the wonderful session. I think Ajit's lecture was fantastic, particularly. Of course, that's not to say the others weren't very good, but I think for the pediatricians, this was very new, and it was put forth very simply and in a way that they were not intimidated. Otherwise, they would have been ablated. So let's go on to this quiz. And I'll do this quiz. I think it captures all what was discussed. So let's take the simple first arrhythmia. And here's the arrhythmia. So this is a child, you've come to a PICU, the child is recovering from a major abdominal operation, patient is on ventilator, is paralyzed. And which of the following actions is most appropriate when you want to understand this arrhythmia? You've been called to identify what this arrhythmia is. So the answers are A, administer adenosine and obtain ECG during administration. B, obtain a rectal temperature and check the level of sedation. Child is said paralyzed. C, a trial of low energy synchronized. I'm sorry, I forgot to mention that, but synchronized cardioversion. And D, administer a fluid bolus of 10 ml per kilo of isolate P. So these are 4 choices that you have to make in this child who is a 4-year-old in a PICU recovering from a major abdominal operation, is on a ventilator and paralyzed.
First get temperature and then get in.
Okay, so I would recommend if anyone's contemplating thinking of the answers, don't do it loudly. And if you are doing it, keep yourself muted, because this is a very useful arrhythmia to, I mean, this is an important arrhythmia, so one has to get it right. I'll give you 5 seconds and then I'll go on to the next question. All right, can I move on to the next question, Dr. Unni? Or do you want a little more time?
Please do,
Hello?
sir. Please do, sir.
More on.
Okay, next question. this was beautifully covered by Dr. Zulfikar. Which of the following facts about adenosine are true? Doses in excess of 200 microgram per kg can result in a potentially fatal cardiac arrest. He was talking about having a defibrillator around. So this is point number A. Point number 2B is that it should be stored between 8 and 12 degrees in a refrigerator, the chiller compartment of the refrigerator. C, administration of adenosine should always be obtained by accompanied by an ECG record during and after administration. So even after the event is over, you should still get a 12-lead ECG. D, carotid sinus massage is an effective substitute for adenosine for children with tachyarrhythmia. So quickly, dose beyond 200 microgram per kg can result in fatal cardiac arrest. It should be stored between 8 to 12 degrees in a refrigerator. Administration should be accompanied during and after ECG. And D, if you can't give adenosine, give carotid sinus massage. Okay, I'll go on to the next question. Can I?
Yes, sir.
Right. So here's this 6-month-old regular tachycardia, just to make your life easy. Heart rate is 280. It's a regular narrow QRS tachycardia. He's crying, but otherwise stable. And you do not have adenosine. Okay. So this question is going to be slightly controversial because I have we may have some interesting discussions that may follow. But what would be the most appropriate choice of action? And it's slightly interesting, and maybe there are more than one correct answers here. A low energy synchronized cardioversion. You cardiovert this child and terminate the arrhythmia. It could be even 0.5 to 1 joules per kg. Give verapamil slowly. Don't give it fast, but give it slowly over actually 10 minutes, and monitor ECG. Simulate the dive reflex by placing a plastic bag with ice and little bit of water so that it conforms to the face for about 10 seconds. D, give amiodarone first as a bolus, maybe 5 to 10 milligram per kg, slowly over an hour, followed by an infusion. So choose one of 4: cardioversion, verapamil, simulate the dive reflex by placing a plastic ice bag with ice, and D, amiodarone. Okay, so we'll go on to the next question. Sorry. The next question. The following ECG was obtained in a child and the same rhythm that I showed you after conversion to sinus rhythm. Which of the following are true? A, the ECG offers a precise clue to the underlying mechanism of the tachycardia. B, ECG offers no clue to the underlying mechanism. C, ECG offers a possible clue to the underlying mechanism. D, even though the ECG offers no clues, in this case, it must be obtained as in all cases after the tachycardia terminates as a routine. So, which of the following is true of the 6-month-old child who had this tachycardia of 280 per minute, who got terminated and an ECG was obtained? Which of the 4 is true? Precise cause is identified. The basis for the tachycardia is identified. There's no basis identified, perhaps identified, or even though it is not identified, it's a matter of routine. Okay, the last question, and this is ECG has been shown by Edwin, I think. So if you had paid attention to his talk, you would have got it right. So just give me a diagnosis: ectopic atrial tachycardia with 2:1 heart block, and junctional tachycardia with retrograde conduction, sinus node reentrant tachycardia. There's such an entity for those who had familiar. Atrial flutter with 2:1 heart block. So 4 possibilities: EAT, junctional tachycardia, sinus node reentrant tachycardia, and atrial flutter. So we are done with the quiz. And we could go to the answers once. We will go through the answers and then we can see who gets it right most often. Is that acceptable, Dr.
Yes.
Pramod?
Yes, yes.
Okay,
That's
let's
it.
go to
Yeah,
the
we'll
first
do that.
question.
Yes, sir. Please do.
Yeah.
So the first question's answer is, so here's that example of that sinus tachycardia that we had shown you, because this is a setting for sinus tachycardia. There are many causes of sinus tachycardia, but one of the things that happen in a PICU is child is paralyzed, but underneath the paralysis, the child is awake. And that produces a ridiculous amount of tachycardia. Anxious child, he could also be dehydrated, could also be febrile, could also have be on inotropes. So all these reasons, the child can be having extraordinary levels of tachycardia that you normally don't see in such children. The clue to this is that it is sinus because you're seeing this one-to-one AV relationship, but that doesn't necessarily mean it's sinus. The best clue is to watch for some time and you see these variations in heart rate, you realize it's not fixed. Also, you must obtain a rectal temperature in a child because the surface temperature could be pretty all right. The child may not be, on you touch the child, you may not be febrile, but when you get a rectal temperature, you might find a very high level of fever and the extremities may be cold. Or most likely, you check the level of sedation. If the child is awake underneath the paralysis, that produces really significant tachycardia and consistently so. So that's the answer. Obtain a rectal temperature and check the level of sedation. Other answers, that is B, is the correct answer. Adenosine, you should not give it as your first choice. Very rarely you have to give adenosine to resolve sinus tachycardia. Almost always you can find the cause and take care of that. Cardioversion is incorrect, unacceptable. Fluid bolus only after you've identified dehydration as a basis for tachycardia. So the first answer is B. Answer is B here. So here's an example of sinus tachycardia where you see the variations in heart rate. In the same patient obtained, a 12-lead ECG was obtained after some time, and very clearly you can see it is sinus tachycardia. Which of the following facts about adenosine is true? 200 dose of 200. Actually, Dr. Zulfikar, I've never seen cardiac arrest after adenosine, and I've never had a situation where I've had to use a defibrillator. So I would say that it is true that you should have a defibrillator when you're giving adenosine in the ER, because a defibrillator should be present in an ER. But even if you don't have a defibrillator and the child is in SVT and you have adenosine, you should give it, because by and large, you can take care of the tachycardia. You won't get a cardiac arrest. And so even doses as 300 mics per kg are completely reversible, because adenosine has an extremely short half-life, and usually whatever you see with adenosine is very short lasting. So nothing to worry. B is incorrect, and one of the reasons why adenosine doesn't work, because people keep it in the refrigerator. Adenosine should be stored in room temperature, not in the refrigerator. It's one of the reasons why adenosine is not effective. C, that is the answer. I'm sure many of you would have got it right. It's a crime to give adenosine and not record the ECG. I'll put it to that level. It's a crime, because if you are encountering a SVT for the first time and you get an ECG record with adenosine, it's a gold mine for somebody like Ajit Tachil subsequently, because then there is a very clear record of the underlying mechanism of the tachycardia. You almost have a precise diagnosis. So adenosine, you should record during and after the event. During the event, you will see what it does in terms of termination. You'll see how it terminates, whether it terminates. And then after the record, you will see perhaps the underlying basis of the tachycardia. Carotid sinus massage should not be administered. I think Dr. Zulfikar mentioned about not doing carotid sinus massage in children. It doesn't work, it's dangerous, and it should be avoided. So the answer is C. And here is what happened to this patient when we gave adenosine. You can see that the manner in which the tachycardia terminates, and you see the inverted P wave when the tachycardia it terminates at the end of the termination, is a very useful clue in these patients out here. In this particular case, the P wave is inverted out here, and then it's upright when the adenosine is administered. So this is a very useful clue to suggest that this is a reentrant tachycardia, and perhaps AV reentrant tachycardia, because the P waves are coming well after the QRS complexes. So this is a very useful clue for the electrophysiologist. So this is something that all of you should endeavor to do. Even if you can't get 12 leads, 6 leads, 3 leads, 1 lead, something. Okay. So same child, and you do not have adenosine available. My answer is C, actually. Dr. Zulfikar could have answered D, but I have a difference of opinion. My second difference of opinion with Dr. Zulfikar, I don't give amiodarone by and large to a reentrant tachyarrhythmia. I think by and large, if you don't have adenosine, you can try to simulate the dive reflex, which is very effective in children. And I will essentially involves, placing some ice inside a plastic bag with a little water that makes the bag conform to the face, keeping it over the face for 10 seconds after taking permission from the parents. Usually at the end of that, the child takes a very deep breath, like you typically have a dive reflex, and this terminates the tachycardia in a good number of patients. So I find it very useful, particularly you can't get IV access. Child is extremely irritable. Then this is not a bad choice. Verapamil is contraindicated. Cardioversion is a possibility if the child is unstable, but ideally it's cruel to cardiovert without sedation, without an IV line. So I think cardioversion is the last resort. I find the dive reflex very useful. So the other option, of course, amiodarone. I'm not a fan of amiodarone in children. I seldom use it. I've found that amiodarone is sort of a de-intellectualization of arrhythmias. You can give it for every arrhythmia and sort it out, but it doesn't help in resolve the underlying mechanism. So we must try to terminate a tachycardia in a manner that we can help identify the mechanism of the tachycardia, if possible. So my first choice for SVT, if adenosine is not responsive, is if you can't get the if the dive reflex doesn't work, is actually I choose a beta blocker in many situations. So here is the fourth question, that is after you've terminated the tachyarrhythmia, you've got this ECG, and you can see that you can actually identify delta waves which are positive in V1, V2. You can see them very clearly. You can see them in almost all the leads. You can see a very short PR interval. You can see a positive delta wave here as well, all throughout the precordial leads except for V6. Suggests that you have a clear underlying basis. So the answer is A, precise basis is identified. Again, a gold mine of information, very clearly tells you what the underlying mechanism is, and you know what you're dealing with. Last question. I think everybody would have got it right. Atrial flutter with 2:1 heart block. You can see the sawtooth pattern. But if you're not able to see the sawtooth pattern, you can give adenosine and you can see how it's unmasked. You can see the heart rate slows down. You see V1, it's very impressive. You can see the typical 4:1 kind of conduction that you're seeing out here. Very, very illustrative. Thank you. So we got the answers listed here once again, B, C, C, A, D. And we can look at how everybody is done.
So now we have Dr. Vikas Kativa, who scored highest in this quiz. Congratulations, Dr. Vikas Kativa. Can you please show your number or your photo or something like that? Dr. Vikas Kativa is here. He's got the first prize for the quiz. Congratulations.
Can you tell me how many he got right?
His mark is, he's got 11 marks. So he got 3 questions right, but then with the sequencing with the marking system, he got 11 marks. The second person is Maria, we got 8 marks. Third is for Vinod, he got 6 marks. So
fantastic. Thank you.
The first question nobody got right.
Sir, yeah, first and fourth question nobody got, fourth question nobody got it right.
Yeah, well, I think I'm surprised, but sinus tachycardia is one of those things that people get it wrong very often. I have seen some pretty horror stories of, amiodarone being given. And when you go to an ICU, when you go to a situation like that, one should think of sinus tachycardia first. When the child doesn't have a background of heart disease particularly, and it can be tricky sometimes.
Thank you. Thank you so much, Dr. Krishna Kumar, Dr. Zulfikar, Dr. Edwin, and Dr. Ajit Tachil. It was an excellent session. I think there is a question from Renu. Says tips to differentiate atrial flutter from fibrillation.
I'm sure one of the speakers should take that question, I suppose.
Okay, probably
Can
Ajit
take the
is
Edwin
around.
or Ajit or Zulfi, anybody.
I can take that.
Yeah.
Am I audible?
Yes.
Yeah.
Okay, all right. So differentiating atrial flutter from atrial fibrillation is relatively straightforward. In atrial flutter, you see P waves, fairly regular P waves of one particular shape. In atrial fibrillation, you do not see P waves. You do not see P waves of any particular shape. And almost invariably, the ventricular rate is irregular in atrial fibrillation, but don't go only by the ventricular rate. The reason is that there is a maximum speed that the AV node can conduct to. Sometimes when the AV node is really conducting at the maximum speed, a 12-lead ECG may not pick up subtle irregularities in the ventricular rate. But the P wave, yes. In atrial flutter, you will see the P wave. The P wave will have one particular shape. Every single P wave will have exactly the same shape, and the P wave will have a regular rate. Atrial fibrillation, usually you do not see P waves. Even if you do see P waves, they will be of all sorts of varying shapes, big, small, invisible, and of irregular rate.
Thank you, everybody. I think we are going to close the session. If there's any comments that any of you want to make before we stop, any of the faculty, any comments?
No, I think you're doing a phenomenal job. I mean, the IAP Cochin should be congratulated, but Jason, I think my hat's off to you to have just pulled this off so beautifully in the last 4 or 5 sessions. I think it's been incredible. It's going to be hard to sustain, as I said earlier. I think you may have to reduce the frequency as we are getting busy, but we shouldn't stop this. We should do this maybe on an ongoing basis at a frequency that we're comfortable with.
Definitely,
Thank you,
sir,
Dr.
that is the plan. That is the plan. For now, we are planning weekly, but then as the time goes, maybe bi-weekly or monthly once. But definitely, it's a long-term program by IAP Cochin.
Thank you.
And the other thing is that probably 500 capacity Zoom is necessary now. I know that you have YouTube also, but I think you need to have ability for others to reach out and join this session.
Sir, the problem is the cost. The cost is almost, so right now we are paying 1,500 rupees per month. But if you want more than 100, then it's going to be 15,000 per month.
Okay.
That is not viable in the current scenario because we don't have any sponsorship. But we do have a YouTube channel which got a hit of about 600 views in the last meeting and about 300 views in the previous meeting.
Okay.
And
that's fantastic.
That is like ongoing. So every week the views are getting increased, and I'm sure this particular session also has good viewership, and it stays online forever until we remove it.
No, and the number of people getting onto and seeing the clips after the session is over is amazing. They are teaching sessions. You'll have done a fantastic job with this particular issue in the tachyarrhythmias in children. And I'm sure all the PTs will. It's going by word of mouth. That a lot of people are entering and seeing what these sessions are all about. Thanks to all of you all.
Thank you.
Zulfi, any comments?
Yeah, no, thank you, Sijisan. Because it's because of you I managed to get into this time. Last time it was because of KK. Anyway, thank you, Jason. And I think Edwin.
Thank you.
How are you?
Yeah, fine. Thank you all.
That's till I meet once in a while.
I think I request Johnny to give the vote of thanks, please.
So thank you all those who participated in this program on the name of IAP Cochin and IAP Kerala, and especially thank all the speakers who there were excellent talk, and it was really a scientific a very good scientific session. I hope everybody has enjoyed it. So especially thank Dr. Krishna Kumar, Dr. Sulfikar, Dr. Edwin Francis, and Dr. Ajit for their excellent speech. And also thank all the seniors and all the PGs who have attended. I also congratulate Dr. Vikas Katewa for getting first prize in the quiz. And till we meet again next week with another exciting program, we'll close the session for the
Just
time
before
being.
you close,
Thank you all.
Doctor, 1 minute. Dr. Narayanan has just passed on a message that he wanted to say that we need to express our condolence for Dr. Kawasaki, who passed away today at the age of 95.
I see.
So he just wanted to share this information in this forum. Remarkable man who's contributed tremendously to, I think, the lives of so many children who have been affected. So I thought we should share this information.
Thank you, Kushal. So shall we leave? Thank you. See you next
Thank you.
week again with the next Potpurri. Thank you.
Bye-bye.
Good night, everybody. Thank you very much.
Good night.